Thank you for having me. I'm honored to participate on this symposium. My name is Joanny Torino, and I'm going to be talking about gastrointestinal health in Parkinson's disease. I have no disclosures. Today, I would like to talk about the proposed pathophysiology of GI disorders in Parkinson's disease, the prevalence of GI manifestations in Parkinson's disease, discuss the most common GI disorders and the treatment options. So the pathophysiology of GI disorders in Parkinson's disease is not well understood. And there is a hypothesis called the Brack's hypothesis, which believe that Parkinson's disease originates in the intestine and then it spread to the brain via the vagus nerve. And this theory comes actually from studies and in rat models. For example, most recently, if you inject these misfolded alpha-synuclein proteins that are the ones that you can find in the brain of patients with Parkinson's disease, if you inject this proteins in the intestine, they get absorbed through the intestine, travels to the vagus nerve, that is a big nerve that goes from the brain to the intestine, goes all the way to the brain, and then that proteins can deposit in the brain. But if in these rat models, if you cut the vagus nerve, then these proteins will never travel to the brain. So that's where we start thinking, well, maybe Parkinson's start from the intestine all the way to the brain, enteric nervous system to the central nervous system. Again, it's still controversial, but this is one of the theories. And this might explain why patients with GI disorders can actually present with symptoms even 12 years before the diagnosis of Parkinson, GI symptoms. In the studies, you can see that once patients have GI disorders 12 years before the diagnosis, and once you get the diagnosis, it increased all the way to 80% of all the patients with Parkinson's disease in 5 years can keep on increasing the prevalence of GI disorders. And we know that Parkinson can be divided in motor symptoms and non-motor symptoms. So non-motor symptoms are cognitive impairment, neuropsychiatric disorders, autonomic dysfunctions like in GI, sleep disturbances, among others. And we know that these non-motor symptoms can affect quality of life, can lead to hospitalization, and actually 80% of the patients with Parkinson's can have GI dysfunction. And we know that this can be accompanied by alterations in the gut microbiota. And this is most recently, this is a mechanistic pathways that where you can see the relationship of gut microbiota and Parkinson's disease. And everything starts with environmental toxins, right? Environmental toxins is one of the theories that patients exposed to environmental toxins can develop Parkinson's disease later in life, and how these pesticides and heavy metals can go into the lining of the intestines. And the lining of the intestine is just one line of cells that they are together, joined together in a line by these proteins forming tight junctions. So these pesticides or heavy metals can alter these tight junctions, causing disturbed epithelial barriers, so changing the permeability of the intestine. And if you change the permeability of the intestine, you can change the microbiome as well, and you can alter the immune activation of your body, which can travel and be this gut microbiota can disrupt the microbiota gut-brain axis with the vagus nerve involved, and all of these can lead to gastrointestinal and motor dysfunction in patients with Parkinson's disease. So it's interesting also to see that constipation, which is one of the most common symptoms in Parkinson, can be manifest, as I told years before. And in this Danish study, they follow patients with constipation for 20 plus years, and they show that actually patients with constipation have even 4-fold increased risk of suffering from Parkinson's disease. So what are the symptoms of constipation? It's not just not having 3 bowel movements per week, it's straining. You can see it here. More than 80% of the patients said straining. Lumpy stools, that they are tight pellet-like stools. Also, the sensation of incomplete evacuation, that you cannot empty completely the stool and that you feel that that stool cannot pass, even if you go every day. The feelings of abdominal fullness, bloating, and also the need for using glycerin suppositories, enemas, or sometimes need to do digitalization, like taking actually stool from the rectum. And we know that there are subtypes of chronic constipation symptoms, patients. The majority of the patients, as you can see, up to 60%, they have normal transit constipation. That means that the colon is moving normally, but then you have constipation for other things, right? 30% of the patient can have something called rectal evacuation disorder, meaning that rectal evacuation disorder, meaning that they can have trouble with defecation, that I will talk a little bit later. Less of the patient has what we call slow transit constipation of 10-15%, and some can have combined rectal evacuation disorder with slow transit constipation. So what are the causes of constipation in patients with Parkinson's disease? We know that slow transit constipation can be found. The patient with Parkinson's disease can have more rigidity in their muscles, so those muscles are not relaxing well to letting the stool come out. And one thing that is more common actually is patients with pelvic floor disorders. And in the pelvic floor disorder category, we have what we call Dyssynergia. Means that the anal sphincter is tight, right? And when you want to defecate, you need to generate rectal pressure, and that anal sphincter needs to open and relax in order for the stool to come out. And instead of happening that anal sphincter is not relaxing and it's not letting that stool come out. And that's what we call Dyssynergia or paradoxical contractions. In patients with advanced Parkinson's disease, we know that inadequate fluid or oral intake also can affect and cause more constipation. Ignoring the urge to defecate also, if you are in bed or busy doing other things, can affect that. If the patient cannot get into a commode on a sitting position, also can affect that. And of course, polypharmacy. Medications that we use for Parkinson can cause more constipation, anticholinergic medications as well, diuretics, opioids medication, calcium, iron, calcium channel blockers, all of those drugs can cause more constipation. So what is the treatment for constipation? So number one, we need to make sure there's not obstruction like cancer, malignancy, or other secondary causes like medications. And if we cannot change all the medications that the patient is, so then we start with, we give lifestyle modifications. And we talk about let's increase diet in your fiber, which I will discuss a little bit more in the next couple of slides. If there's no response, so then we start with bulking agents. We want that stool to be bulk, and we recommend fiber supplementation like psyllium. And if this fiber supplementation is not enough, then we go to different type of laxative, which I will discuss. We have the osmotic laxative, the stimulant laxative, the chloride channel laxative, and the prokinetics. If there's no response, so we need to do more investigation. So what are the lifestyle modification? Number one, avoid dehydration. It's not that you're drinking a lot of water all the time, but yes, avoid dehydration. It's important to eat breakfast because depends on the breakfast. If you have 300-400 calories, that can help induce a reflex called the gastrocolic reflex. So it goes from the brain through that vagus nerve to the stomach, to the small intestine, and an hour later, people feel the urge to go. So we want you to have breakfast because usually that happens a couple of times a day, especially in the morning. When we recommend high fiber diet, a lot of fiber can cause gas. So you can also consider, if you have trouble with the gas, consider high fiber but low gas producing foods. And there's a recent study talking about kiwi fruit, and kiwi fruit has tons of vitamins, and at the same time, this study showed that it can increase bowel movement with more sensation of complete evacuation and without producing gas. So 2 kiwis a day seems to be a good fiber without adding the issues with the gas. prunes is used widely, but we know that it's very high or smaller, so it can cause gas. If you have a lot of GI trouble symptoms, then consider eating vegetables, but cooked vegetables. Cooked vegetables are more easily digested than non-cooked raw vegetables. And then we recommend our patients to increase the level of daily activity as you can, and avoid medications that can cause constipation, like anticholinergic drugs if possible, tricyclic antidepressant, especially opioid medication. So we know that fiber is not for everyone. So fiber is better for patients with normal transit constipation, like you see in this orange column. But if you have slow transit constipation, so fiber is not going to help you as much. If you have a rectal evacuation disorder, might help you a little bit, but it can cause some more trapped gas in some patients. So it's not for everyone. So that's why high fiber in the diet is important, because if you add too much supplementation, might cause more problem in some patients. So the osmotic laxative, which are this one? These ones are medications like Miralax, magnesium, lactulose. These medications are, some are non-absorbed substances that go into the colon and then cause water to go into the colon and then help having bowel movements. So polyethylene glycol, like Miralax, the dose that we use is 17 grams. You can use it once or twice a day. Is very safe. And these medications are meant to take every day, not whenever you feel that you're constipated, because it works better, the lowest dose that make you have bowel movement without diarrhea, but on a daily basis. Magnesium oxide, also I use it a lot. There's a liquid form, there's pill form. Liquid form is in the form of Philip milk of magnesia. You can use 15 mLs, 30 mLs, all the way to 45 mLs if necessary. The maximum dose is 60 ml on a daily basis, right? 15, 30 mLs on the daily basis. If you prefer pills, so 500 milligrams, 1 to 2 pills at bedtime. There is a new study showing that the dose for constipation with magnesium is 1,500 milligrams is what patients usually use. Lactulose is used, but then that causes a lot of electrolyte disturbances and diarrhea, so it's less used. And I try to avoid magnesium and lactulose in patients with renal or cardiac insufficiency to avoid the electrolyte disturbances. So these studies show how Miralax or PEG can actually increase complete bowel movements up to 6 months compared to placebo. Stimulant laxatives, what they will do is induce secretion, and they act in the myenteric nerve plexus and will accelerate transit. And example of these drugs are Senna and Bisacodyl laxative. And in the study, you can see how Bisacodyl 10 milligrams compared to placebo improve constipation. But the adverse events are diarrhea, abdominal pain, so some patients discontinue. In my practice, I use it in combination if the patient is in fiber, in osmotic laxatives, and needs, haven't had a bowel movement in 4 days, and they are uncomfortable 4 to 5 days, then taking 2 pills of Bisacodyl at bedtime can be a rescue therapy. We try not to do it on a daily basis. Some of the patient needs on a daily basis, but we try to do it, at least I try to do it more rescue therapy, because there's other drugs that we can use as well. So another group of laxative is the chloride channel activators. And these chloride channels will put chloride and sodium to the colon, so causing diarrhea or moving your bowel, right? The most commonly used is linaclotide. The other name is Linces. And linaclotide, a dose of 290 and 145 milligrams, improve complete spontaneous bowel movements compared to placebo. The major issue with linaclotide is in 20% of the patient can cause a diarrhea. And some patients decide to discontinue. So this medication, you need to take it on an empty stomach. And if you start having diarrhea, usually it's in the first week or so. So we ask the patients, just try to keep on taking it. If in a week or 2 weeks, the body kind of get used to it, to try to avoid discontinuation of the drug if possible. So the company created a new, a lower dose, 75 milligram for those patients that they don't tolerate the diarrhea side effect. Lubiprostone is another of the laxative of this category, and lubiprostone 24 milligrams twice a day also help the mean spontaneous bowel movement per week. But the major issue is that one of the most common adverse events is nausea. So patients that has all the underlying nausea, we try to avoid it. Plecanatide is kind of the same mechanism as linaclotide, and also it's only one dose approved, is the 3 milligram, and we use this one for patients that linaclotide causes too much diarrhea. This also is an alternative because it causes less diarrhea and is effective. Prucalopride, which is a 5-HT4 agonist, is you can find these 5-HT4 receptors in all your GI tract. So have shown also to improve constipation compared to placebo. This medication is a promotility agent, so it helps the stomach, it helps the small intestine and the colon as well. Less side effects is diarrhea. I don't think is as strong as Lynn says with causing diarrhea. And this medication has been tested in elderly population, is safe, has been tested also in Parkinson's disease, which is safe. One of the issues is that this medication has a black box warning that patients that have depression that can worsen depression. We have not seen this happen. We give it to patients with antidepressant medication and depression, but it's important to tell the patient that if their depression symptoms are getting worse, then one of the things that we consider is discontinuation of this drug. Otherwise, it's very safe, is well tolerated, and is different than cisapride. In the past, cisapride is a partial agonist of this receptor, and it was linked to cardiovascular event. This is a complete agonist, so no risk of cardiovascular event. The other patients that I will not give prucalopride if you have migraine headaches, because it can worsen migraine. But the efficacy of all this laxative that I'm telling you between the chloride channel and prucalopride seems to be, when you do a meta-analysis, seems to be kind of comparable. So what if you fail laxatives and you fail lifetime modification? So what we do next? So we need to evaluate for rectal evacuation disorder. And this drawing shows the pelvic floor anatomy. And at rest, your pure rectalis muscle, that is this sling muscle that is wrapping around the rectum, is usually contracted, and the anal sphincter is contracted as well. When you defecate, this sling muscle needs to relax, the anal sphincter relaxes, and then you have appropriate descent of the perineum with complete evacuation. So patients with rectal evacuation disorders is common. It can be up to 20-30% common in Parkinson's disease, and we divide it into spastic pelvic floor disorders and obstructive disorders. The spastic disorders are that dyssynergia that I was talking about, the paradoxical contraction, and also that we see in women's pelvic tension myalgias, that they have more pelvic pain as well. The non-spastic or obstructive disorders are when you have organ prolapse, like vaginal prolapse, rectal prolapse, or descending perineum, meaning that when you are descending to defecate is more than 3 centimeters. So it's too much, and that obstructs defecation. So patients with, in this study, for example, 12 out of 19 patients newly diagnosed with Parkinson's disease present an abnormal anorectal manometry, although some of them were not presenting with a lot of symptoms. And this is one of the issues with the test, is not perfect. But the good news is that when you treated patients with levodopa carbidopa, that paradoxical contractions actually improve with Parkinson medications. So that's a good news without changing the transit time. What we do in the office, we do a rectal exam to evaluate for this condition, which is very comparable to an rectal manometry, which will be the gold standard, where we put a catheter in the rectum, in the anal, passing the anal sphincter of the rectum, and we can measure the anal pressure and rectal pressure at rest, during squeeze, and during evacuation, and then see if you have this condition. Other things that we can do to diagnose is we do, if the patients already have a CT scan or an MRI, we can check for gas in the rectum. And if you have gas in the rectum, it's more suggestive of a rectal evacuation disorder compared to slow transit constipation. And if you have obstructive defecation symptoms and we suspect you have prolapse, so that we have the MRI defecogram, where we can inject some gel in the rectum and actually dynamically see the process of defecation and see if there's any prolapse or obstruction during defecation. If we rule out, if the patients still have constipation and we treated the pelvic floor disorder, then we suspect a slow transit constipation. We can do colonic transit or scintigraphic studies, or we can do a wireless pH motility capsule, which can also tell us how the transit of all your GI intestine. So what is the management of dyssynergic defecation or a rectal evacuation disorder? Is biofeedback. Biofeedback is with physical therapy. Generally, there will be talking later about this today. But if you compare biofeedback training program to laxative, to sham, to diazepam, to Botox injection, biofeedback training program is better. The success rate depends on the institution, can be 70 to 80%. There's studies in Parkinson's disease that actually it can be effective for Parkinson's disease, 69%. So it maybe is a little bit less than in normal population, but it's still effective. So it's something to consider. And this is an example while doing biofeedback training program. This is a patient that at the beginning have no rectal pressure, and then the anal sphincter was tight, right? So you see the spasms here. After physical therapy, this patient start generating rectal pressure and the spasm is less. And then finishing physical therapy, you can see how the patient now has better rectal pressure, and then the anal sphincter is relaxing for defecation. So the take-home point from chronic constipation is that we know that patients if you are not responding to lifestyle modifications and laxative, in patients with Parkinson's disease, you should consider dyssynergic defecation or a rectal evacuation disorder. Do diagnostic tests. Important is to understand that you can use different treatment options for constipation, including bulking agents, laxative, secretagogues that are the chloride channel secret, and the prokinetics. And you can use it in combination. It's not one or the other one. And then biofeedback should be considered in the appropriate patient. So other common symptoms of GI manifestations in Parkinson's disease can be oropharyngeal dysphagia. And these can be seen in up to 50–80% of the patient with Parkinson's disease. And the problem is more deglutation, like how you start swallowing with your tongue, putting the food coming back down to the throat, to the esophagus. And the symptoms are coughing when you're eating, choking with the food. And what we do is we refer to an ENT specialist, ear, nose, and throat doctor, and a speech therapist as well. To diagnose this, we do a video swallow study where you drink some contrast, and you can actually see the dynamics of deglutation, and the speech is in combination with the speech therapist, and we can give you they can give you different consistencies and food and teach you some maneuvers to help you swallow, and then we look if there is any aspiration, like the food is going to the wrong pipe, like people say. And then it's good because the speech therapists give you a treatment of how to swallow as well with the study. Esophageal dysphagia is extremely common as well. 80% of the patients with Parkinson can have trouble swallowing, food getting stuck, or they have heartburn. They can have acid regurgitation, chest pains, and even weight loss because it's difficult to swallow. The problem with dysphagia is that it can reduce markedly the quality of life. The patients start having trouble drinking their own medications. It can lead to malnutrition and also to aspiration pneumonia. So when we do an esophageal manometry study to evaluate for dysphagia, we pass a tiny catheter all the way to the nose, and then we give you water to swallow. We can see if how is the peristalsis, which means the contraction of the esophagus, is that food pipe, how the bolus goes down. And in patients with Parkinson, we can see many things, right? We can see some patients can have absent peristalsis, like meaning no contractions. Some patients can have weak peristalsis. Some patients can have actually a hypertensive esophagus, like the contractions are very forceful, or a spasm. And those are the present maybe with some more chest pains. And commonly also we can see something called EGJ outlet obstruction, which means that that lower esophageal sphincter in between the esophagus and the stomach is kind of tight, and the food is not going through, but it's not an entity, less likely achalasia. No, it's not so seen in Parkinson's disease. It's more that outlet obstruction. What we recommend, so we recommend lifestyle modifications, right? Try to sugar your food, drink water after swallowing. You can crush your pills. You can go to the pharmacist and say which drugs I can open capsule, which drugs I can crush, and then you can take it with applesauce, for example, those to help you the absorption as well. The good news is that if you optimize your Parkinson's disease medications, your esophageal disorder can get better. And also there's multiple ways to manage reflux, right? Between proton pumps inhibitors, H2 blocker, combination of those can help reflux, as well as trying to avoid reflux producing foods. Some patients with that entity that I said, EGJ outlet obstruction, or esophagus that contract forcefully, we can inject Botox to that area to help relaxation, and so the food can go down. And then prucalopride, some studies have, some case reports have shown that maybe helps the motility, because we don't have a drug to help motility of the esophagus, but that's we are not sure yet if that's true or not. So nausea, extremely common in patients with Parkinson's disease. Is a common side effects of levodopa, which is the drug for Parkinson's disease. But also there's other stomach conditions that can cause nausea. So dyspepsia or indigestion, which means that one of the things that cause dyspepsia is that the stomach is not accommodating to let the food come in. So it's kind of, instead of going from fasting to fed state, it's kind of tight. And that can lead to nausea, early satiety, feeling full. And when we do a gastric emptying study, that is a meal, radio-labeled egg meal, you eat it, and we can see that the gastric emptying can be normal. Or we have nausea can be seen in patients with delayed gastric emptying also when we do that gastric emptying study. So the stomach is not emptying well, we call it gastroparesis. And what we have seen is that idiopathic gastroparesis is more a problem of what we call the gastric pacemaker or intestinal cells of Cajal. But in patients with Parkinson's seems to be more neurohumoral signals via the vagus nerve again and myenteric plexus. The dyspepsia treatment is important to rule out Helicobacter pylori, because Helicobacter pylori is a bacteria that is in the stomach that can cause the same symptoms of nausea, dyspepsia. And we see that is common in patients with Parkinson's disease. And actually, H. pylori have been shown that can affect the metabolism of the Parkinson drugs. So definitely needs to be eradicated. Other things that we recommend is small frequent meals, low in fat, try to avoid stress, improve the sleep, which I know that is hard, but studies from our group have shown that if you don't sleep well, that stomach cannot relax well neither. And we use different medications for dyspepsia or accommodation of the stomach, meaning Iberogast, which is a herbal compound. We will not give it in patients with liver disease. because it's herbals, and there were 2 cases of liver failure. So I will not give it in patients with liver disease. Otherwise, seems to be very effective. Patient like it. Other medications can be mirtazapine, which is an anti-anxiety antidepressant that helps the stomach, help for sleep, help for appetite. Buspar, an anti-anxiety medication, also have shown to accommodate the stomach. And I try to avoid nortriptyline, especially in patients with Parkinson's disease, because of the anticholinergic effect. So delayed gastric emptying, so symptoms of delayed gastric emptying or gastroparesis can be seen also in patients with Parkinson's disease. And it's the same symptoms of dyspepsia, but then patients can have more pain, more vomiting, not so much pain. Pain is in both, but they can have vomiting, weight loss, malnutrition. And what is the treatment for gastroparesis? The most important is hydration, and seeing a nutritionist for doing a gastroparetic diet, which involve low fiber, low fat, blenderized food. You mash your food. You take your medications, as I told you, crush. That's the culprit. Avoid cook. The other things that to avoid is avoid, for example, metoclopramide or Reglan, because it's a peripheral dopamine receptor antagonist, so that cannot be given in patients with Parkinson's disease. Domperidone is peripheral dopamine antagonist, so that will be okay, but it's not FDA approved in the US because of sudden cardiac death. You can find it from Canada, elsewhere. We try not to give it because of that reason. Erythromycin, which is a prokinetic, also seems to be okay in patients with Parkinson. Prucalopride, as I discussed before, that can help for constipation, but it helps emptying the stomach, so it's a good alternative for patients with gastroparesis. We give anti-nausea medications as well, knowing that especially Zofran can cause constipation, so that's something to keep in mind. And then it's important to manage constipation, because if you are constipated, you can have more upper GI symptoms, sometimes even have mild delayed gastric emptying because of that reason. So future therapies, I want to discuss a little bit about, touch a little bit on the microbiome and the role of microbiome. The future therapies and microbiome, where we don't have a lot of data, but 3 things have been proposed, and they are under developing or being considered to study. One, it would be good to have drugs that can be developed to prevent microbial uptake of the L-DOPA and degradation within the GI tract. We know that the microbiome, when you take the L-DOPA, the microbiome can degrade this medication. So then the patients need higher levels of levodopa, causing more side effects. So it will be a good way managing the microbiome, so to avoid, to try to use less amount of drug to avoid side effects. But there's 2 studies that have shown that lactobacillus and bifidobacterium species for 12 weeks a decreased movement disorder versus placebo, so that's promising. Bacillus subtilis also helps a therapeutic effect by inhibiting and reversing alpha subnuclein aggregation, the protein malformation. And what is right now in clinical trials that is also will be good also to keep on investigating on it is fecal transplantation, which in my studies, so fecal transplantation helped prevent the development of Parkinson's disease on mice that were expressing the alpha subnuclein protein, the protein that affects in Crohn's disease, in Parkinson's disease. So fecal transplantation is also something in the near future that there is undergoing clinical trials. And with this, I would like to thank you